Bismillah ar-Rahman ar-Rahim. Welcome. This video is in cooperation with Student Council and Peer-Assisted Learning Group, especially to discuss the topic diarrhea. This is Dania Alkelabi, Pediatrics resident at King Saud University Medical City. We're going to cover the topic diarrhea, which is a symptom for different etiologies. We're covering the topic on a student level in order to make the medical student confident and, in the same time, a safe physician in managing diarrhea cases. So we will define diarrhea, discuss the pathophysiology and how it happens, and discuss different differential diagnoses, especially acute and chronic causes with emphasis on the acute causes. And we will discuss rehydration techniques and management of diarrhea. It is just a glimpse on the topic. Throughout this video, you will find different tables that you can take screenshot from. It can give you a summary about the different causes of acute and chronic diarrhea and the specific management for them. But throughout the video, I will only give you a hint or a stimulation for your mind and an approach to think about diarrhea in a systemic way. So let's start with this scenario. Imagine that your colleague, which is a parent for the first time, has a boy which is 8 months old. His or her boy passes 5 bowel motions per day, and your colleague is asking you, is this normal? I mean, for adults, we know that 5 bowel motions per day is a lot. It's more than what we are used to. But for a baby or for someone in this age, is this normal? This question will stimulate you to think about, well, actually, what is diarrhea? How do we define diarrhea? If this baby has only single bowel motion, which is watery, can we say this baby is having diarrhea? Or it must be like 3 times or more? Is it about the frequency or the consistency or both of them? I try to bring different definitions of diarrhea into this slide. Generally speaking, excessively loose stools is considered diarrhea when it is more than 10 milliliters per kg per day if it's an infant, or more than 200 grams per 24 hours if it's in the older children. These numbers help us to know it in a scientific way. But generally speaking, if the child passes 3 or more watery stools per day, this can be diarrhea. But it also differs when it's an infant, because an infant up to 8 times per day is considered normal sometimes. In toddlers, 3 times per day may be normal. So it differs upon the age. It differs upon the patient's normal bowel habits. And this is the most important factor. You have to remember to always ask the patient's usual bowel habits. If this baby usually has 3 bowel motions per day, and now he's looking sick with increased frequency for 5 times per day, and the consistency is like watery in comparison to his usual bowel motions, then you think about maybe it's diarrhea, maybe it's something that we think of as diarrhea. So let's talk about the Bristol stool form scale. It is one way to help you in asking someone about the stool, to understand whether this stool is into the hard side or the watery side. From 1 to 3 here, these forms are more into constipation. 5, 6, and 7, these are into the watery or the not well-formed stools, and these may come as diarrhea. especially if it's with increased frequency. So let's go together into some facts about diarrhea. Most of the water is absorbed in small intestine, which are here. Smaller amount of water is absorbed in the large intestine. We have to know what dysentery means. Dysentery is usually a symptom of colitis, which is inflammation of the colon. When someone has inflammation of the colon, no matter what the cause is, he might have dysentery, which is passing small volume of stool frequently, which may contain blood, and there is urgency and pain. He's feeling like he must pass this bowel motion urgently, but actually it's not producing a large amount. The bowel is inflamed and causing him to feel that he needs to pass something. This is more with the large intestine, while passing large amount of stools is more when the pathology in the small intestine. This is one way of thinking of it, and we will talk more about different way of classifying the causes of diarrhea in the next few minutes. All diarrheas is disturbed intestinal solute transport and water absorption, and we will talk about this in a few minutes. If you want to think about diarrhea in a systematic way, you can classify diarrhea in different manners. You can think of it whether it was acute or chronic, and this is by the duration. If it's more than 2 weeks, this is chronic or persistent. If it's less than 2 weeks, this is acute diarrhea. And according to that, there are tables that summarize to you the differential diagnosis for acute diarrhea and the ones for chronic diarrhea. You can think in another way, considering the mechanism of this diarrhea. Is it osmotic, secretory, inflammatory, or motility related? And we will go through that. You can think of it as infectious or non-infectious. It can be due to viral, bacterial, or parasitic infection. You can think of it as many different ways. The child exposed himself to a metal that caused this diarrhea? Did the child have functional diarrhea causing these symptoms, which have different management? So let's move to the mechanism of diarrhea as the topic of this slide. Go together through the mechanism of diarrhea. It may be due to different causes. The yellow small circles over here represent the digestive material. When we ingest anything, like for example, the baby takes the milk and it goes through the intestine, whether large or small intestine, it passes over the area. During the passage, water and nutrients are absorbed to the wall of the intestine, which has blood vessels, which deliver the water and nutrients to the systemic circulation, and the baby or the child can have benefit of this. Diarrhea can happen in different mechanisms. One of the mechanisms is when there is no enough water absorption by the wall. If there is damage to the wall, or if there is problem with the channels of sodium or chlor, or the channels that are helping in absorbing water, then the water will stay in the digestive material. It will stay over here in the digestive material, and the stool will come out watery, not as firm as a normal stool is. This is one mechanism of diarrhea. The other mechanism is when the water is pulled into the lumen due to osmotic gradient. And this is in the osmotic diarrhea. When there is too much sodium, for example, or there is too much glucose or too much sugar or something other than that, as for example, when a child ingests propylene glycol by mistake, which is used as solvent and other uses. It has high osmotic gradient in comparison to the baby's or the child's blood. So it draws the water from the circulation in the small blood vessels in the walls into the lumen, and then it's more watery stool. The third mechanism is when there is, for example, the cholera toxin, when there's a cholera infection. When the toxin make the channels in the wall of the intestine produce the water and secrete it due to abnormalities in the channels, then the water is in an increased amount in the stool and it goes out watery. So we discussed briefly on the past chart the osmotic and secretory diarrhea mechanisms. The difference between the two is that in the osmotic diarrhea, the diarrhea is caused by the water getting dragged into the lumen of the intestine, which is this area, because of the digestive material itself. While the secretory diarrhea, no matter if there is a digestive material or not, no matter if the patient have already eaten something or have been fasting or not, the water will be secreted anyway. This is the difference between the two. So in the osmotic diarrhea, you will have moderately increased amounts. The diarrhea stops if you ask the patient to fast, because if no digestive material that drag the water, no diarrhea. While the secretory diarrhea, it will have very large amounts, and the diarrhea will continue despite fasting. The last difference is the ion gap or the fecal osmotic gap. This is the formula that when you ask the lab to take a sample of the stool, you take a sample of the stool, you send it to the lab, and then they calculate the fecal osmotic gap, and they apply this formula. If the numbers are high, which is more close it's more close to thousands, this is more of osmotic diarrhea. And then you think of the cause of this diarrhea as one of the differential diagnoses in the table that discusses osmotic causes. But when the number is low, which is more close from the zero, then you think of the table that mention the secretory causes of diarrhea. We will have tables in the few next slides, as I will show you over here. This table will give you examples on the secretory causes and the osmotic causes over here. We'll explain the mechanism and we'll have extra notes on it. And also it will discuss other causes of diarrhea as increased motility, decreased surface area, and mucosal invasion. In the real life, actually, it's not only one mechanism. You can have secretory and osmotic diarrhea in the same time. So it's important to link the clinical picture of the child and to ask about the history and to know the clinical features to help you narrow your differential diagnosis. We move on now to the fun and important part, which is differentials of diarrhea. And one efficient way of discussing the differentials is classifying diarrhea into acute and chronic causes. We start first by the acute causes. Most of the time, acute diarrhea, which as we discussed earlier, less than 2 weeks or less than 14 days, it's commonly due to gastroenteritis, systemic infection, antibiotic associated, or overfeeding. These are the most common causes, and there are other rare causes that you can look at over here. In different age groups, there are different causes. For example, an infant cannot say no sometimes to if the mother feeds the infant too much, he will have diarrhea. So overfeeding is one of the causes for infants. Child may have something different. Adolescent may have something different. So it's also help us in narrowing the differential diagnosis. But the most important and the most common cause of acute diarrhea, which is an infectious diarrhea, is the gastroenteritis, which is, as we see, itis, it's inflammation, gastroenteritis, inflammation in the GI tract, which can include the intestines. So as we see over here, the most common etiology of gastroenteritis is viral, especially rota, calci, adeno, and astroviruses. Rotavirus these days has a vaccine, and that's good to prevent it. One thing is it can be bacterial due to Salmonella, Shigella, Campylobacter, E. coli, or Clostridium difficile, which causes pseudomembranous colitis, which can happen as a result of ingesting antibiotic for a certain duration. Then Clostridium difficile gastroenteritis happens. Parasitic causes also are possible, as Giardia and Cryptosporidium. I want to share something with you. It's an interesting fact. I used to think of the gastroenteritis from food poisoning as only being transmitted by food, but also it can be the infectious gastroenteritis can be transmitted from one person to another. So it can be a viral or a bacterial infection transmitted either by food or by person-to-person contact or so on. It manifests clinically as diarrhea, vomiting. It might be also associated with abdominal pain and systemic features as fever. And whenever you have systemic features as fever and malaise, decreased level of activity, you think of an infectious causes and most likely viral, as we mentioned. I will put in the next slides tables from the Nielsen textbook of Pediatrics that show us the most common viral, bacterial, and parasitic causes, because each one has different incubation period and each one can have different symptoms. So if you want to take a look at it as the source of it, from where we can get it, these tables are very beneficial. Moving on to the treatment of gastroenteritis. Let's first mention something. We don't always give antibiotics for patients with gastroenteritis. There is certain indications to give an antibiotic. If the patient has sepsis or extraintestinal spread of bacterial infection, or has Clostridium difficile infection with pseudomembranous colitis, we usually treat them with vancomycin, and sometimes we give them metronidazole. Cholera, Shigella, and Giardia, and Salmonella infection in patients under 6 months old, and immunocompromised patients, because if they can't totally fight this infection on their own, they need the help of antibiotics. I want to mention as well a common mistake that people used to do in the community, which is giving anti-diarrheal agents. We used to hear people that say, okay, if you have diarrhea, go to the pharmacy, get a medication that stops this diarrhea. If we think of it, when it's an infectious diarrhea, we want the organism that's already invading the GI system to go out of the body. We don't want it to stay inside the body. So why we want to give anti-diarrheal agents? If the patient is losing nutrients, losing water, losing glucose, we can compensate it. But let the organism go out and don't give anti-diarrheal agents. This is a very helpful chart that I brought from illustrated textbook of Pediatrics. It shows how we manage gastroenteritis, especially when there is dehydration or not. So if there are no clinical features of dehydration in the patient, we encourage oral intake. Oral intake is important to prevent dehydration as a result of the fluid loss by stool or vomiting by gastroenteritis. There are some solutions called oral rehydration solutions, or ORS. As an example of it, we have Pedialyte. They are solutions that contain both water and electrolytes. And also it may contain glucose, so it makes the fluid compensate the loss and also in the same time stay in the body for a longer time. If the patient show clinical signs and symptoms of dehydration, or if already in shock and unable to take oral fluids, then we may proceed to intravenous therapy for rehydration. And once you move to intravenous therapy, please consider to check the electrolytes for the patient, plasma electrolytes, and check also if the patient is having enough glucose, is not getting into hypoglycemia. So remember to assess for signs of complications. So not every gastroenteritis passes easily. Sometimes the patient gets sepsis because of gastroenteritis, and the patient looks sick and have fever and so on. So you have to look for these signs when examining the patient. And also sometimes the bacteria invades and there's invasive bacterial infection. So you have also to check if it's a complicated gastroenteritis. But in usual cases, there are no needed investigations. In usual cases, neither labs nor stool culture is needed. But if we talk about some instances when you give, for example, fluids as IV fluids, or there are signs of hypernatremia because of fluid loss, then consider ordering plasma electrolytes to check if the patient's still on the right side. Consider ordering urea and creatinine to check if the rehydration is affecting the patient's kidney. And also check the glucose level and check if the patient is going into hypoglycemia. You may consider ordering stool culture if the child appears to be septic and the stool has blood or mucus. If the patient is immunocompromised, we want to treat him promptly in a timely manner. So we must know the organism itself and treat it precisely. If there's history of travel, if there's diarrhea, which is not improving by day 7, then you may consider stool culture as well. Let's go back to differential diagnosis. We already mentioned the acute causes. Now we'll go to the chronic ones. Chronic diarrhea has multiple causes, and it is really important to check the growth charts in any child that has chronic diarrhea. If he's losing the nutrients in stool before it gets absorbed, then it might affect his growth. Check it. Check how it affects the weight and the height of the child and how the chart looks like. Is he declining in the growth charts? So there are many causes for chronic diarrhea in children. It might be infectious causes. It might be related to immune deficiency. It might be like celiac disease. It might be food allergy, IBD or inflammatory bowel diseases, related to malabsorption as pancreatic insufficiency or insufficient bile acids or cholestasis. Sometimes it's cystic fibrosis, lactose intolerance, and other causes. Each of these points are a topic by themselves, so it should be described not in this video. This is only to give you a glimpse about these features and to keep in mind that whenever you ask history questions to the parents, if you are suspecting one of them, don't forget to ask about the other symptoms for each of them. But now let's talk briefly about the post-enteritis syndrome. Post-enteritis diarrhea syndrome is when someone tells you that my child is doing well, he already passed the gastroenteritis period. I can tell that he passed the period of gastroenteritis, But still, since he had the gastroenteritis, I noticed he's having diarrhea. He didn't have diarrhea like that for a long time. Well, we're talking about, in this case, gastroenteritis that is resolved, but left a diarrhea that lasted more than 14 days. So this is a chronic diarrhea due to post-enteritis diarrhea syndrome. What is it? There are many hypotheses, but one of the common ones are sensitization to food antigens. Some foods are not well tolerated by the child after gastroenteritis. And some hypotheses also hypothesize that the small intestinal mucosa has damage, which is still persistent. Other hypotheses include alterations in microbiota, so sometimes they give them probiotics. Okay, so as we mentioned, there are differential diagnoses for both acute and chronic diarrhea, and in each age group, they have different causes. Please check this table to give you better information about the different causes, and consider looking in the history and in the physical examination for signs and symptoms of each of them if you may suspect. In the following table, you find clinical presentations that suggest having an infectious cause for this chronic diarrhea, and it gives you a hint for which organism it might be. This is a stepwise approach for approaching a child or an infant with chronic diarrhea. As we mentioned, a good history for the child and for the parents is important, and then the clinical examination and so on. But don't forget also that sometimes the prenatal sonography can give you an indication if they saw something abnormal, the feeding history, family history, and consanguinity, which is mother and father being related. One of the things also that you may do is allergic workups. If someone has a suspected allergy to a food component, you might start a trial to eliminate this food component and see if it responds, or infectious workup as to cultures, parasites, and viruses. You may proceed actually with laboratory tests, stool analysis, for example, or other tests that may apply for differential diagnosis that you suspect. You may order for alpha-1 antitrypsin level. You may ask for fecal leukocytes and calprotectin. Also, imaging has a role. You may proceed to imaging as abdominal ultrasound or X-ray with contrast studies. Endoscopy and histology has a role, and please look at the description below. Genetic investigations are sometimes required, and other special investigations as sweat test in case of cystic fibrosis. So as we mentioned earlier, whether it's acute or chronic diarrhea, the most important thing whenever the patient steps to the ER or to the clinic to make sure is the patient hydrated or not. And as we mentioned, water is replaced, and then the electrolytes should be replaced as well. And Pedialyte is one of the things that we can use orally. I highly recommend this video in YouTube with this title, Diarrhea by Melanie and Dr. Bridget. The video describes in brief diarrhea from different aspects as well as differential diagnosis and management. Special questions that you can consider in history is to ask questions about the disease and the stool itself. Is the stool having blood? If it has blood, it might be an upper or lower GI source, and this can be differentiated by either being black stool or into bright red stool. It might be also pale. If it's a pale stool, this might give us an indication about a problem with bile. Physical examination is for two things. The first one for dehydration and signs of shock, and the other thing is for signs of the underlying disease that causes diarrhea. Investigations, as we mentioned, can include fecal osmotic gap, special tests according to the differential diagnosis, and blood gases to make sure that the patient is not affected by this dehydration in a bad way. And further management can be taken accordingly. So what to check clinically in examination to know if the child has dehydration or even signs of shock? Well, you check the skin for different things, including reduced skin and reduced tissue turgor. You check also if the skin is pale or mottled. You look for the mucous membranes if they're dry, eyes are sunken and tearless, the baby is crying without tears. You check the vital signs, and clinically you look if the child has tachypnea, increased respiratory rate. You look at the hands, prolonged capillary refill time, that can be in the hands and also here. Regarding urine output, it may be reduced. And the most important thing that I want to drag your attention to is the accuracy of measuring dehydration by knowing if the patient has a decrease in his weight. So it's actually the most accurate way to know if the patient has lost a lot of fluids during the diarrheal illness. This table is beneficial to differentiate if the patient is having dehydration in different degrees, if it's only a clinical dehydration or it has progressed to shock. Whenever the child has one of these red flags, make sure it doesn't progress to shock and try to manage them promptly. This lecture was prepared from these references, including Nielsen and illustrated books. Thank you very much for listening to this lecture, and feel free to contact me and ask any questions on daniaclabi@gmail.com. These are my Twitter and LinkedIn accounts. All thanks to Student Council at King Saud University Medical School and to the peer-assisted learning for this great opportunity to share with our lovely young colleagues. Have a nice day.